Good morning, everyone. Thank you for joining us here in November for GIM Grand Rounds. As a preview, the month of November, we of course today have Dr. Phil Hitchcock and revisiting the annual physical exam. Next week will be the clinical case review with Dr. Elena Lebduska, and the week after that will be Dr. Emily Jones talking to us about foot and ankle pain. Again, today we have Dr. Phil Hitchcock, and really excited for him to talk to us about the physical exam. Phil joined the university in 2020. Before that, he attended college at Lehigh University, medical school at Tulane, and did his residency at Tripler Army Medical Center. Phil is the associate director for physical exam for DOCS, which is developing our clinical skills with the first year medical students. And that's where I've worked with Phil, and truthfully, he's taught me quite a bit about the physical exam. It's something that we learn in medical school, gets reinforced during our residency training. But I thought this was a really important and timely topic because how often do we get more information or get direct feedback on the physical exam as faculty? And so that's why I'm really excited for him to help educate us today. Phil.
All right. Thank you, Steve, for that introduction. And thank you, everybody, for coming to Grand Rounds today. When I was first asked to do this talk about physical exam as the associate director of the physical exam, I wanted to do something novel, something kind of fun. And I realized that I was never really taught what to be doing exactly for, quote, an annual physical or what the evidence was. So I decided to do my own review with evidence for many different physical exam maneuvers and try and create a quick exam that we might be able to apply in primary care with high yield maneuvers that would be applicable to asymptomatic patients and potentially catch serious disease. So I want you to look at this in the primary care lens as a simple exam that will still allow you to lay hands on your patients, but not take up too much of your time, but also potentially catch serious things that we can intervene on. If you don't see particular maneuvers in here, that's probably because there isn't evidence for it, or I didn't find great evidence for it in this setting of the annual physical. But that's also another thing that I want you all to realize is that there isn't a lot of great evidence for a comprehensive physical exam in an asymptomatic patient. And this is an evolving talk, and if there's any feedback, on what other people do, I'd love to hear it. So I don't have any disclosures. Our learning objectives, so we're going to review the history of the annual physical. We're going to develop or have a basic understanding of how likelihood ratios affect post-test probability, and this is how we're going to sort of define our strength of physical exam maneuvers. And then we're going to go through a screening exam or an annual physical consisting of evidence-based maneuvers. So let's talk a little bit about history of medicine, history of the annual exam. So the general physical annual exam, this became popular in the early 1900s. Beginning in around the 1910s, it was necessary for work clearance. And this was in the setting of industrial and manufacturing jobs and served as a tool for pre-employment and periodic health surveillance to assess fitness for work and prevent occupational illness. In the 1920s, it was endorsed by the American Medical Association to screen for diseases before they became clinically significant. It was then considered the standard of care for 50 or so years. In the late 1970s and early 1980s, the utility of the annual physical kind of came into question by multiple major associations. And that included the ACP and the USPSTF. And this is around the time that we were in medicine having a shift more to evidence-based and risk-based approaches to medicine. Interestingly, though, the annual exam in the setting of the industrial manufacturing jobs, this really is what gave birth to what we now consider occupational medicine today. Oh, and I'll say here also, the USPSTF now even recommends against certain physical exam maneuvers for screening. Example of that would be lung auscultation for COPD. but at the same time, they haven't really looked closely at lots of other different maneuvers, such as auscultation of valvular disease or lymph node palpation for malignancy. So despite questions about the physical exam component, annual visits, or we might call these periodic health assessments or Medicare wellness visits, are still common practice. They're often fully covered by high deductible insurance plans, incentivized by Medicare. We now generally accept that these focus more on the age appropriate counseling and screening rather than an actual physical exam. For example, welcome to Medicare visit, only the blood pressure measurement, vision, and weight and height are recommended. But many of our patients, as you probably all know and experience, still expect a physical exam. And in one study, those expectations were blood pressure measurement, heart-lung exam, abdominal exam, and even reflex testing. So what are we supposed to do? Are we not supposed to touch our patients at all when they come in for these annuals? Turns out that even if the probability of physical exam is low, detecting subclinical condition in a healthy patient, it has been shown to have other benefits. This includes sense of crucial contributor to the physician-patient relationship, creates a special sense of caring to the patient, conveys a sense of empathy and solidarity, and it can have its own therapeutic effects in patients by expressing relief and gratitude after a normal exam. So what do our medical students learn now? So we still teach in most medical schools, they learn a complete head-to-toe exam. And this is done in a core and clusters approach or hypothesis-driven approach. For example, core exam is going to include inspection and auscultation of the thorax, and you might sort of start with this exam in someone who presents to, for example, the emergency department. And then you can supplement this by a symptom-driven cluster of questions and exam maneuvers depending on the chief concern, or if you found any abnormalities in the lung exam in this example. So for a patient with fever and cough, this would evoke additional maneuvers like tactile firmness and agophony. However, amongst medical schools and residencies, there's a significant variance about what designates core versus additional exam. And this is typically based on expert opinion rather than evidence. What do we do as primary care physicians? Arguably, with the rapid advancement of technology, access to labs and imaging, physical exam has taken a back seat. And I want to be the first to say that that's not wrong. We should be embracing technology and using it to make us efficient and better doctors. And also, the utility of the physical exam is different depending on your setting. So are you inpatient versus outpatient? What specialty are you? Arguably, physical exam is very important in neurology. Maybe you just do an abdominal exam in general surgery or press on the belly. What's the concern? Is it a new concern? Are they coming in for follow-up or something, or is it their annual physical? But at the end of the day, our patients still expect a physical exam in many clinical settings. So what's the evidence, which we're going to go through? There are many studies that look at the sensitivity, specificity, likelihood ratios of physical exam maneuvers as they apply to specific disease presentations, like pneumonia. There is a lot less evidence for a comprehensive exam in healthy asymptomatic patients. So we'll start getting into our annual physical. And again, before I get started, I just want to reiterate, this is what I built. It started with reading the book by Steve McGee called Evidence-Based Physical Diagnosis. And as I read through that, I made note of high yield maneuvers and then actually looked to the studies that were referenced to kind of understand the context in which these physical exam maneuvers were studied to see if we could apply these to this annual physical setting. And again, my goal is to create something that we can do in 5 minutes. It would catch serious disease. It just allows us to sort of still lay hand on our patients. You'll also notice that a lot of this is going to feel tailored towards the older patient. which, we see a lot of. And, you'll be able to sort of pick and choose it however you like with these maneuvers, but that's in part because our older patients are going to be the ones that are at greater increased risk for the possible diseases that I talk about. Okay. So a comprehensive physical exam is certainly not needed. We are going to focus on general appearance, vital signs, head and neck, pulmonary, cardiovascular, and the abdominal exam. Before we do that, I'm going to do a quick review of likelihood ratios because this is how I chose and how we're going to look at physical exam tests as gauging whether how good they are or not. Just recall likelihood ratio. This is a measure that tells you how much a test result will change your probability or post-test probability of a disease. It combines the sensitivity and specificity of a test into a single metric. It's typically more clinically useful than sensitivity or specificity alone. And they're nothing more than diagnostic weights, and interpretation of them can be pretty straightforward. You can calculate them using or how likelihood ratios change probabilities of disease. You can do it precisely by converting a pretest probability into odds and then multiplying it by the likelihood ratio. But no one's going to do this at bedside in seeing a patient that has potentially several complaints. So it's impractical and there's an easier way to do it. So if you've never seen this graphic before, this comes from Steve McGee's book on evidence-based physical exam. And what you're looking at is a ruler with likelihood ratios. So on the right-hand side are our positive likelihood ratios. On our left-hand side is our negative likelihood ratios. And you'll see markers of, on the right-hand side, 2, 5, and 10. So that's a likelihood ratio of 2, 5, and 10. And right above that, you see the percentage. And that's how much, roughly, this is crude, a test result, positive test result, increases the percentage of disease. So if you had a test result, say agophony for pneumonia, likelihood ratio 5, that would increase your the post-test probability of pneumonia by 30%. On the left-hand side, if you're trying to sort of remember this in your head, 0.5, 0.2, and 0.1 are just reciprocals of the right-hand side. So we've got 1/2, 1/5, and 1/10. And they decrease percentages by the same amount. All right, so let's move into the actual exam itself, starting with general appearance. So this starts when a patient walks down the hall and continues throughout the entire encounter. I recommend doing this. Observe ambulation. And you can consider doing mini mental status exam if you have some concern for dementia. And for fall, if you have concern for falls, 2 different things: standing with feet together and eyes open, or observing to see if they stop talking when walking. So observe your patient ambulating if you can, i.e. walking past your office, maybe walking them out of the office when done with the exam. It can give you a good sense of how well they're moving and how steady they are on their feet. Also turns out that it can be a good clue in recognizing conditions like Parkinson's disease. So just as a review, Parkinson's disease, the amount of cases we're seeing are increasing about 1.1% per year from 1990 to 2021. That translates into about 450,000 new cases in 1992 and 1.34 million in 2021. If you see a Parkinson's gait, and I'll show you a picture of this on the next slide, this has a likelihood ratio, positive likelihood ratio, ranging from 3 to 15, depending on what study you're looking at. So that's almost a 20% to greater than 50% increase likelihood of someone having Parkinson's. I'll also mention that in my experience, people can downplay, especially kind of when I see older men with new diagnoses of Parkinson's, they'll downplay their symptoms. Gait is one thing that it's pretty hard to hide. Arguably, tremor, rigidity, and bradykinesia can be difficult to hide too. But this is just an easy thing. You just watch your patient and they don't know maybe you're watching them. So this is a picture of Parkinson's gait. So we have the flexed posture, we have the diminished arm swing, we have the narrow base gait, and we have the shuffling steps. Let's talk about mini mental status. So this is also evaluated throughout the entire counter. You often don't need to do this specifically, such as what's the date, what's the time, what's the location. If you have a concern for dementia or cognitive impairment, the mini mental status exam has a good likelihood ratio of about 7.8 if the score is less than 23. Other screening things like the MOCA have similarly good scores as well. If the score is greater than 23, this has a negative likelihood ratio of 0.2, so that's about a 30% decrease. You can also follow this over time, but there must be a change about 4 points for us to reliably indicate any sort of significant change in cognition. And recognize sensitivity. Yes, question.
My question is, what's the gold standard against that? If like less than 23 only confers a 30%, 7% increase, what is the diagnostic modality that determines that they have it, even though, or they don't have it, even though the score is lower?
Yeah, so you're asking kind of what did they use to compare this score to true like dementia, neurocognitive decline? I'd have to look specific. This references 10 different papers. And I don't remember for each one, but I think it's along the lines of kind of a more extensive neurocognitive evaluation like we do. We send them to, the extensive testing that they have. Does that answer the question? Okay. Sensitivity ranges 47 to 100%. So keep that in mind. And also note that patient education can affect the MMS, the mini mental status exam score. So a highly educated patient may be able to sort of do a little bit better on this when true cognitive decline is absent or is present, I'm sorry. Let's move on to quick falls assessment. So falls occur at least once annually in 29% of persons over the age of 65 living in the community. So this is about 0.67 falls per person per year. 10% of these falls result in serious injuries such as fractures, joint dislocations, sprains, strains, and concussions. And annual screening is recommended for patients over 65. If you have a concern for falls, some quick things you can do. Well, first, a history of a fall during the previous year has a likelihood ratio of 2.4 for another fall in 6.12 months, so not great. But if a patient can't stand with their feet together and eyes open for 10 seconds, this has a likelihood ratio of 4.5 for predicting a fall. And this is something that you could quickly or easily do if you're getting them to get up onto the exam table to say, hey, I'd just like you to sort of stand still, eyes open, for 10 seconds. Just see how they do if they start feeling if they're off balance. Stops walking when talking has a likelihood ratio of 3.0 for predicting falls. And I'll sort of say an antidote. So my father has Parkinson's disease. He's doing fine. But when I visited him a year ago and we were walking and I asked him a question, I noticed he stopped walking and then answered my question and then continued on. And then he did this again. And turned out about 6 months, and within the next 6 months, he did have two falls. And I hadn't started this talk yet, and I sort of put 2 and 2 together after that and just found it interesting in my own experience. And so I actually do walk out all my patients. I use that time to chit chat with them, but that would be something I'd be looking for if asking about their kids or something, if they feel like they have to stop. Yes.
I really like the idea of seeing how the patients are walking. It's not part of my current workflow in the clinic, right? Give my patients back to the MA, they do the labs, they do the stuff, and then they leave, right? I'm not seeing the patients, I'm not walking them out after the fact. I'm curious what changes you've made to your workflow in clinic to allow you to do this in a way that sort of flows well with the rest of the clinic session.
Yeah, and so I'm at Cherry Creek. I don't know how different we do things than Anschutz, and I'm sure each of our practices are different. If a patient doesn't need any lab work or anything, then I'll walk them out on my own. If they do, the lab sheet is down the hall, and sometimes I'll try and do that, or if my MA takes them, I will try and watch them. My office, intentionally my desk faces the door. And so I can see that, but yeah, if I wanted to sort of ask them questions while they're walking, I would need to sort of do that. But I'm set up in a way where I can easily see their gait and do it myself if I need to. Yes.
In the chat, we have a two-part question. Do you do the get up and go assessment when patients are leaving? And then followed up with what's the evidence behind that?
So good question. Uh-oh, did this just freeze? Here we go. Yeah, the get up and go is another test that is often talked about for falls. Turns out, and that's when you have the patient rise from a chair, walk 3 meters, turn around, walk back, sit down. So likelihood ratio for that, based on studies I looked at, was 2.6 or positive likelihood ratio if it's greater than 35 seconds. If it's between 15 and 35 seconds, it's not significant. Where I think that the get up and go can be helpful is if it's less than 15 seconds, it has a negative likelihood ratio for 0.1. So significantly decreases the risk for the fall. But it's not a great test we don't really, in general, arguably have great tests for predicting falls.
So this is a comment by me, but given those likelihood ratios you just said, it sounds like a more time efficient strategy is doing something like the stand with your feet together, close for 10 seconds rather than go through the get up and go.
Yes, and that's my intent for kind of trying to create these and pick out these particular maneuvers, because you can sort of, what you're doing already, incorporate these. Thank you for making that point for me, Steve. All right. If you don't have any more questions here, I'll move on. Okay. All right, so let's move on to vital signs. These are routinely obtained before entering the room. We have lots of likelihood ratios for things like tachycardia, hypotension as they apply to specific conditions in the hospital, things like chest pain, et cetera. Primary care, we typically use these more as a way to monitor conditions like hypertension, COPD, AFib, obesity, et cetera. Recommend doing this, so obtain the vital signs as you usually would, and also feel the pulse. I do want to put in some plugs for blood pressure technique and measurement, and technique really matters, and I think this has become more and more evident in the literature that's put out regarding how to take blood pressure. So ideally, it should be measured with the patient seated in a chair with back supported, rested for 5 minutes, arm at the level of the heart and supported. The length of the blood pressure cuff should encircle at least 80% of the arm circumference. And you should obtain 2 readings separated by at least 2 seconds, or 30 seconds, sorry. And a recent study, I believe this is in JAMA in 2023, showed a mean overestimation of 19 points of blood pressure when a regular cuff was used, when an XL was needed. So all these things are important, but arguably I think that really making sure the blood pressure cuff is the right size for the patient is one of the things that we should really make sure we're doing, and all our staff are aware of it. Additionally, if available, we should all be using unattended automated office blood pressures. It is as accurate as the gold standard ambulatory BP monitoring. And if you're not aware of what this is a machine that basically your staff can check in the patient, put the cuff on the patient, and it will take usually 3 blood pressures within several minutes while they're sitting in a quiet place. There's a lower prevalence of white coat effect. It reduces the human error in blood pressure management. And there was another study that actually found that routine office blood pressure measurement overestimates BP or blood pressure by a pooled mean of 14.5 points compared to unattended automated office blood pressure when the systolic blood pressure was greater than 130. So I would argue with this tech, if we have the ability to get these in all the clinics, we should, and we shouldn't be doing manual blood pressures anymore. Let's talk about feeling the pulse. So incidence of atrial fibrillation in persons 65 to 74 is 3.5% per year and increases to 6.21% per year for those who are 75 years or older. It's a relatively common thing I think we see in our population, and it can be asymptomatic. Turns out that chaotic pulse, just by feeling it, is a good indicator that AFib is present. In this study, with 20 seconds of observation, we found that the finding of a chaotic pulse has a likelihood ratio of 24.1. So this essentially diagnoses atrial fibrillation. And they define chaotic pulse as ventricular beats that are completely irregular and unpredictable. And so I would say if you're considering doing EKGs for your annual visits and you're doing this to screen for AFib, to me, this is an argument that you don't need to do that. And there's actually recommendations against EKGs yearly, which is a different conversation. But you can do this while you're auscultating the heart, which is another way you can sort of sync up the beats. Let's talk about head and neck. So examination of head and neck, this can be done relatively quickly. Has a potential to detect serious disease. Do this. Palpate the supraclavicular lymph nodes. Consider looking for conjunctival rim pallor if there is complaints of fatigue. So the supraclavicular lymph nodes, these are strategically located at the base of the neck, close to where all lymph node drainage returns to the systemic venous system. We're talking about the right node, we're talking about the right thorax, arm, and neck. We're talking about the left node, we're talking about left thorax, arm, neck, abdomen, pelvis, and the lower limbs. This is a picture showing lymphatic drainage. And you'll see on the right-hand side where they're located. So they're just behind the clavicle, underneath the posterior or posterior to the SCM. So if you remember, your SCM is here in your neck. If you push out your forehead like this, you can feel the heads of it. One connects to the sternum, one connects about mid-clavicle. So reaching right behind that SCM, that's where the supraclavicular lymph nodes are going to sit. In studies of patients who underwent biopsy of supraclavicular adenopathy, 54 to 80% of those patients were discovered to have malignancy, and mostly metastatic carcinoma. And 50% of those patients whose biopsies revealed malignancy were unaware of the diagnosis before the biopsy. So this is a sort of argument to me that this is a very high yield area to palpate if we're going to do lymph nodes. I don't think a full lymph node exam is needed, but checking here, you can find some pretty serious disease from anywhere throughout the body. Just some additional features of adenopathy that increase the risk of serious disease. So if they're big, greater than 9 centimeters is pretty big. That has a likelihood ratio of 8.4. Hard texture, 3.2. If they're fixed, so this is a likelihood ratio of 10.9, so you should really be looking for this feature of any sort of swollen lymph node. And then if they're tender, this has a negative likelihood ratio of 0.4, so about a 20% decreased risk of serious disease. Talk quickly about conjunctival rim pallor. So fatigue is a common concern brought up during annual visits. I feel like half my patients in a day report fatigue. Anemia is a possible cause of this. If you have concern for anemia, you can look for conjunctival rim pallor. You do this by looking at I'll show a picture of this in a second, but you pull down the lower lid of the lower eyelid, and a positive sign is if the anterior rim has the same pale fleshy color as the posterior rim. This has a likelihood ratio of 4.49 for anemia, which in this study was defined as hemoglobin less than 9 if this finding is present. But note, the absence of conjunctival rim pallor does not decrease the probability of anemia. We don't have good negative likelihood ratios for it. So this is how you do it. You pull down the lower lid. On the left-hand side, you'll see that the rim pallor is absent. So you've got the reddish color in the anterior rim, pale color in the posterior rim. And then on the right, that would be a positive finding. And then this is what it would sort of look like on a real person. Left being pale conjunctiva, positive finding, and then on the right would be normal. So let's talk about the pulmonary exam. Arguably, this is most useful in patients who are presenting for an acute issue, i.e. pneumonia, has less value in an asymptomatic patient, but auscultation can still be useful in an annual physical exam setting, particularly for detecting things like obstructive lung disease or other more serious, I don't want to say more serious, but other serious pathologies like interstitial fibrosis. So do this, auscultate the posterior chest for adventitious breath sounds. There's many references on how to do the lung exam, and it can include lateral and anterior auscultation. This is just one example. I think for our screening purposes, doing 6 sites in the posterior chest, so 3 on the left, 3 on the right is generally fine. Just want to make sure you're avoiding the scapula and getting the majority of the lung fields. So one of the big buckets of abnormal findings for the pulmonary exam is crackles. So these are discontinuous sounds like rubbing strands of hair together. This is from the distal airways collapse from previous exhalation, and then they're abruptly opening during inspiration. These are very rare in healthy, normal tidal breathing, so these are almost always abnormal findings. Some common causes are obstructive lung disease, heart failure, pneumonia, pulmonary fibrosis. They can be coarse, fine, early or late, but defining them exactly doesn't matter simply as catching them in our sort of screening physical, because again, we're trying to just identify any serious disease. And this is going to be a theme going forward nowadays with the technology we have. Again, we can try and define them as in these different categories, but at the end of the day, we have access to further evaluation, which should be prompted, whether it's chest X-ray, CT, PFTs, et cetera. So basically what I'm saying is I don't want anybody to stress over. Just listen for these and find them. You don't have to define them too much. If we're talking about idiopathic pulmonary fibrosis, so virtually all patients have crackles. This is a basically defining feature of IPF. It may also be the first sign of disease before any other signs or symptoms. And it turns out, actually, so if you for some reason had concern for this, the absence of crackles has a negative likelihood ratio of 0.04 in defining or for detecting features of IPF on a CT. So this basically virtually rules out. If crackles aren't there, the patient probably doesn't have IPF. For chronic obstructive lung disease, early inspiratory crackles has a likelihood ratio of 14.6, so it's a very high likelihood ratio for detecting it. And then also a likelihood ratio of 20.8 for severe disease. So basically, crackles, bad. If you hear this, this should prompt further workup. The other big bucket is wheezes and rhonchi. So wheeze is a high-pitched, continuous musical sound. Rhoncus is typically defined as a low-pitched, continuous musical sound. The pathophysiology of the two are the same. And so both are caused by vibrations of opposing walls of narrowed airways. Think of a balloon that's trying to deflate and you're squeezing the end so it can't. There really is no clinical importance into separating them. And so I would make the argument that you just call them wheezes, whether they're low-pitched or high-pitched, just to avoid any sort of confusion. Seeing this done before forced wheezing, this lacks diagnostic value. You can provoke this in most healthy patients if they exhale forcibly enough. And the longer the higher pitch the wheeze, the more severe the obstruction. Again, thinking of that balloon trying to let out air. If you hold it real tight, real high-pitched noise. You open it up, the airway a little bit more, it becomes that lower frequency. both are obstructions, both are from the vibrating of the sounds. And then studies on wheezing, they almost, all the ones that I found, they couple findings of symptoms of dyspnea, and also wheezing alone is not very specific. But if, again, just like crackles, these are abnormal. If you find them, this should prompt further investigation, maybe further history that you didn't get from the patient before. So when we're talking about chronic obstructive disease, unforced wheezing, this has a likelihood ratio of 2.6 for detecting chronic airflow obstruction. When we're talking about asthma, wheezing plus symptoms has a likelihood ratio of 8.2 for detecting asthma. And this was in a study that looked at people ages 20 to 44. And then reported wheezing, symptoms of wheezing alone has a likelihood ratio of 4. Now, I get that we're talking about asymptomatic patients and sort of screening exam. I will say that I have picked up wheezing in a patient who did not tell me that they were short of breath. And this was a well-compensated, healthy, fit young guy. And then I heard the wheezing, and that physical exam prompted more history from him, which I then got, yeah, my 5-mile runs have gotten harder over the past 6 months or so. This prompted workup. Turned out he did have some degree of asthma, which we then treated. So sometimes you might not get the history from our patients, but some screening like this might pick up something which would then prompt you getting a better history. Okay. All right, so let's move on to the cardiovascular exam. So the cardiac exam can be an effective screening tool for certain cardiac diseases and detect pathology in asymptomatic, minimally symptomatic patients. My recommendation is to do this to assess for lower extremity edema. If you find that, to assess for JVD. Also palpate the PMI, and then auscultate for murmurs. So starting with lower extremity edema, as we all sort of know, this can stem from different causes: increased capillary hydrostatic pressure, like heart failure, venous insufficiency, decreased plasma oncotic pressure, so that's things like nephrotic syndrome, liver failure, increased capillary permeability, so inflammation and sepsis, and then impaired lymphatic drainage, like lymphedema or malignancy. If you find this, the most important physical exam maneuver to follow up with is assessment of the JVP. If you find jugular venous distension or JVD, then a cardiopulmonary process is at least partially responsible. If you don't, then another process is more likely. So unfortunately, we don't have time to talk about how to do the JVD. I have lots of bonus slides at the end that people can look at asynchronously if they want. But turns out finding of elevated JVP, this can be helpful in several different scenarios. So this has a positive likelihood ratio of 8.9 for truly finding an elevated central venous pressure. So that would be greater than, typically done 8 to 9 centimeters, but greater than 8. 6.3 for detecting a low left ventricular ejection fraction. And also positive likelihood ratio of 11.3 for postoperative pulmonary edema, as well as postoperative MI or cardiac death. That's a likelihood ratio of 9.4. And I mention these because we often get people coming in for preoperative physicals or clearance, and they often don't have a complaint, or maybe they're not very mobile, so they don't really know, if I get heart failure symptoms, because they're not really moving a whole lot. But maybe we should be looking at this quickly if we can, considering how kind of ominous the sign of elevated JVD is when they studied it for postoperative outcomes. Moving on to the PMI, so palpation of the heart is one of the oldest physical exam techniques, recorded as early as 1550 BC by Egyptian physicians. There are various areas of the heart that can be palpated, but assessing the point of maximal impulse, or the PMI, this is the most useful. Arguably, this can be difficult to palpate, particularly in patients with more adipose tissue or more breast tissue. think it's estimated about 50% of our patients we're not going to be able to reliably palpate the PMI. But I will say the more you try and do it, the more often you do it, the more familiar you're going to become with what's normal and being able to find it. So this is the area that we're looking at. Again, see the bonus slides if you want to reorient yourself for how to palpate the PMI, how to actually do the physical exam. And it turns out if you find that the PMI is lateral to the midclavicular line, it suggests heart failure. So that's a positive likelihood ratio of 10.3 for detecting a low EF, 5.1 for increased LV end diastolic volume, and 5.8 for detecting pulmonary capillary wedge pressure greater than 12. Arguably, the reference studies here, they did look at patients who had a history that might be suggestive of a heart failure. They didn't look at, quote, asymptomatic patients like we're focusing on. So utility of a displaced PMI in an asymptomatic patient, truly, we don't have a study to sort of know, and I'll admit that. But I think in general, like other things, if you find this and you sort of find a displaced PMI and you're getting better at it, this may then prompt sort of further questioning the patient. Like, are you feeling more short of breath? And really trying to get that sort of historical sort of stress test scenario. Okay, and then auscultation for murmurs. So like listening to, for pulmonary adventitious breath sounds, catching the murmur is more important than characterizing it exactly. Again, we have access to echoes. If you're going to hear anything, you're going to probably get one and really trying to find it better. So I'm just stressing, listen for murmurs. Don't stress too much about, is it systolic? Is it mid-systolic? Is there a rumble, et cetera? And we're not going to review the characteristics and pathophysiology of the murmurs. That's a completely different 60-minute lecture I give to medical students. If you want to do this, it's a shout out to the med school YouTube channel. These have great videos. You can point med students to. I point the med students to them. But 2-minute videos where there's an animation and they play the sound and you can see how the turbulent flow is happening. Really good, quick review of these things. But instead, I'm just going to show you how good the likelihood ratios are for picking up these murmurs. And so this is a chart taken from Steve McGee's book. Just looking here, characteristic systolic murmur. So if we're looking at the first line for aortic stenosis, that would be typically crescendo, decrescendo murmur, likely loudest in the aortic area. You'll probably hear it along the left sternal border as well, or that mid stump or the lub stub sound. But that has a likelihood ratio of 10.5 going down the list. Tricuspid regurgitation, 10.1, mitral valve prolapse, 12.1. Aortic regurgitation, 10.1, mitral stenosis, 31.2. So really good likelihood ratios if you pick up a murmur that there truly is one and truly pathology there. And then this is some more likelihood ratios on third heart sound. Fourth heart sound, not really specific, don't really have any good evidence for it to help us. Okay, trying to wrap things up within the time frame here. We'll move on to the abdominal exam. So it is of limited value in asymptomatic patients, especially with a high proportion of our patients having excessive abdominal adipose tissue. But a quick inspection, this could reveal some serious pathology. And so my recommendation is to inspect the abdomen and then palpate for an aortic pulsatile mass. So inspection, this can reveal serious pathology. If you all recall the Sister Mary Joseph nodule, Sister Mary Joseph, she was a surgical assistant to William Mayo and noted the association between the umbilical nodules and intra-abdominal malignancies in the late 1800s. So this represents metastatic carcinoma to the umbilicus, and it's a hard dermal or subcutaneous nodule. And the reason why we can see it here, there's lots of different routes via vascular, lymphatic, or embryological remnants where carcinoma can travel to the umbilicus. And it can be the first sign of intra-abdominal malignancy, up to 20% in one study. And that's often coming from the stomach, large bowel, ovary, or pancreas. So this is just some pictures of what that might look like. Basically, if you see a weird thing in the belly button, this should prompt further history workup. Additional inspection, so looking for dilated wall veins. This can signify portal hypertension, also superior inferior vena cava syndrome. So in the setting of liver disease and seeing dilated abdominal wall veins, this occurs because of formation of the collaterals from the portal to systemic venous system. If with concomitant jaundice, you see dilated abdominal wall veins, this has a likelihood ratio of 17.5 for hepatocellular disease. And then for patients that we know to have chronic liver disease, if you see kind of new finding of wall veins, this has a likelihood ratio of 9.5 for cirrhosis. Other findings I just want to mention too, spider angiomas, palmar erythema, gynecomastia, these all have, I don't have them quoted here, I don't remember them exactly, but they all have good likelihood ratios for hepatocellular disease and cirrhosis. And what I mean by good is they're greater than like 5. And then superior inferior vena cava syndrome with dilated abdominal wall veins. This is from collaterals due to obstruction, like malignancy or thrombosis. These are typically on the lateral abdominal area, and that's one of the main reasons why I wanted to mention it. So on the left, we see the caput medusa, or the cluster of serpents that we would see in association with liver disease. And then on the patient on the right, we're seeing more the abdominal wall veins dilated in the lateral side, and that's in line with an IVC obstruction. And then palpating the aorta, this is probably something that a whole lot of us don't do anymore, I imagine. And you can see the bonus slides for more detail on how to do this. But it turns out that we actually have pretty good physical exam studies for this in the right patient. So the finding of an expansile pulsating epigastric mass has a likelihood ratio of 8.4 for detecting a AAA. Arguably, smaller aneurysms, 3 to 5 centimeters, they're more difficult to detect. But if we're talking about one that is focal bulging more than 5 centimeters, which is when it's approaching repair, this increases our sensitivity to over 80% in all of the 8 reference studies here that are coming from McGee's book. Obviously, I think, the patient is more adipose tissue, it's going to make it harder. But when they restricted the analysis to thinner abdomens, less than 100 centimeters, or in patients in which the physician just reported, I can feel it, the sensitivity, the exam exceeds 88%. Similar to other maneuvers, absence of a finding does not rule it out. So this is only helpful if you do find it. And then finally, wrapping things up, just a note about skin cancer screening, because I did get some questions about this when I did a similar talk at Estes Park. It is not recommended in primary care for asymptomatic average risk adults. So several studies have failed to show sustained mortality benefit, particularly with melanoma. Some of the harms might include overdiagnosis, unnecessary biopsies, cosmetic psychosocial impacts. It may be warranted for people who are at higher risk. So that's a personal family history of skin cancer, multiple atypical nevi, immunosuppression, inflammatory conditions like IBD. That being said, ABCDE rule for melanoma, it's a decent screening tool for high-risk patients and history of, so like those who have a history of melanoma. And it may detect new melanomas more often and earlier than those that don't self-screen. And here are some of the likelihood ratios for some of those specific characteristics. You'll see here down at the end, evolution. That's probably the most important one. That has a likelihood ratio around 8.4. And they define that in the study as a pigmented lesion that was changing in size, shape, or color. Okay, and then to wrap things up, so this is my annual physical. Take some of it, take all of it, take none of it. We're going to observe ambulation. We're going to obtain vital signs. We're going to feel the pulse. We're going to palpate the supraclavicular lymph nodes, auscultate the posterior chest. We're going to assess for lower extremity edema. If that's present, we're going to look at the JVP. We're going to palpate the PMI, auscultate the heart, inspect the abdomen, palpate for AAA, skin exam, and I put that in question marks because I think there's controversy about it. And that's the end of my talk. So open to any questions. We have time left.
Thanks, Dr. Hitchcock. I have one. We'll get to you, Dr. Ernest. In the chat that I was saving for the end, it was from Barry, and Barry, I saved it because I thought it was a nice global question and comment here. So Barry said it's worth considering for patients with cognitive issues such as developmental delay, TBI, dementia. They can be less likely to report symptoms. And so this may be a time where it's more important to do more exam maneuvers. And so that was a comment, and I'm gonna pivot that into a question for you, which is for patients who have cognitive impairment, how does that change what you're doing for core versus additional or a more comprehensive exam?
Yeah, I think that's a loaded question. I'm looking at and I'm presenting this exam kind of as a mostly asymptomatic patient. And in the setting of, our Medicare wellness visits, often the spouse will come in and say, towards the end, hey, I've noticed that they're forgetting their keys or they're forgetting names, that sort of thing. And I would approach a patient who is coming in with, sort of a primary complaint of a cognitive issue much differently. And if it was sort of the primary concern, I would focus on that. So I wouldn't approach this as kind of like here. But when it comes to the physical exam, I think we are somewhat limited in what we can do in primary care to look into this further. But I think you want to obviously get a good history if there are signs or symptoms that would suggest some of the more common causes of cognitive decline, so Parkinson's disease. So we talked about the gait, bradykinesia, tremor, resting tremor, that pill rolling tremor. So looking for maybe signs of that. Potentially this might include a complete neurological exam as well. So looking for any sort of focal deficits that would clue me into, okay, is there something intracranial? I usually do a full neuro exam when there's a cognitive primary concern. And then, trying to get some sort of objective measurement. So the mini mental status exam, the MoCA, whatever it is that you kind of feel best with.
Barry, you have your hand raised. It looks like you unmuted. Go ahead.
Yeah, can you hear me okay?
You can.
Thanks. So an example would be for people with Down syndrome, whether we should do testicular exams. The feeling is that people with Down syndrome if you're seeing a young person with Down syndrome for a routine exam would likely not report any problems with their testicles. And as it happens, testicular cancer is more common in people with Down syndrome than people without. So the thought is, even though for people without Down syndrome, it's not recommended, with the thought that the patient would report problems with their testicles, in people with Down syndrome, they may not report that. And so it looks like we're probably going to end up recommending that we palpate the testes of people with Down syndrome, where for people without, it's not recommended. So again, different based on the person's ability to report problems.
Yeah, and that makes complete sense to me. And tailoring, an exam, even a screening exam to a patient's history is important. I couldn't speak, I think, intelligently enough about what the overall risks are for certain populations like Down syndrome and what the evidence is for testicular cancer screening. But your argument there makes complete sense to me, and especially if they can't really report any symptoms, I think it would make sense to include that.
So my question is about cardiac auscultation. And I remember as a resident being scolded by an attending for ordering an echo for what clearly to him was a benign ejection murmur and for the waste of that. And to this day, I don't know how to distinguish a benign ejection murmur from early AS, say. And so I'm just curious, did you run across any tips to say if this is present on the exam, you don't need to order an echo, or this characteristic of the murmur?
Yeah, that's an interesting question, and I think different time too, the way I look at it. As far as you talk to some some cardiologists, they think everyone should get a screening echo at some point, right? So I brought these likelihood ratios back up here. As far as there is sort of functional murmur characteristics, 5.4. If you sort of hear that characteristic. I mean, the way I sort of look at it is, if you're not sure, get an echocardiogram. I think it's more important that we are looking for cardiac abnormalities in the setting of finding a murmur and not worrying. You can make the argument of public health, costs of healthcare and things, but I think at the end of the day, the echocardiograms aren't too expensive. But I think to me, it's more important that we all are looking and finding serious pathology rather than worrying, I guess, about being scolded of, hey, this was not worth it or not. And so even if I hear what I think to be a functional murmur, I will get an echocardiogram. It sort of gives me, and people might disagree with this, but it kind of gives me a reason to get a closer look at this person's heart, because I could be wrong, right? So even with 5.4, so that's only, 30% increase of it being functional if you truly feel like it's a functional murmur. So would that give me enough confidence? I don't know. Kind of dancing around there. Does that sort of, I mean, that's my perspective. Yeah, it can be hard to distinguish. I mean, I think you then might want to be coupling symptoms in there, but functional murmur, I mean, murmurs are called by turbulent flow or decreases in valve area. And so if someone's in a sort of high volume state, for example, pregnancy, it's common to hear, quote, a benign murmur during that time. So kind of knowing that history a little bit, but generally there's systolic murmurs, and there's lots of systolic murmurs. They can sound maybe similar to a mild, aortic stenosis or something like that, or sclerosis. And so I think the short answer is yes. I don't think that we are good enough with our physical exam to confidently say, hey, this is functional, this is not. Or I'll say just in general primary care practice as well. And so if you hear one, my recommendation is to say, listen for it and get an echo. And hey, if you're wrong, it's functional error, great. Heart looks great. And you're done.
Dave added an article to the chat about that from article from I think 97 from JAMA. Last question we'll have for today. A few people were wondering about the data for clinical breast exam in asymptomatic individuals.
Yeah, this is a timely question because we just brought this back into the doc's curriculum. It's another conversation why it sort of disappeared. But it is still recommended for a low or intermediate risk patient, meaning like no family history of breast cancer, that the clinical breast exam is not recommended. For higher risk patients, it can be considered. This sort of, I think they sort of describe it as, shared decision making. So, I mean, to me, again, it's sort of like the modern medicine that we're in, we should be using mammograms. Now, if someone has a breast complaint, we should be doing a breast exam, similar to, if a male patient has urinary complaints, we should probably be doing a prostate exam, although we don't do those for screening anymore. And so it is important to know, maybe we do it in our higher risk patients, but as far as the evidence shows, it doesn't seem to be as helpful, and we should just be using the mammogram. Does that answer the question? Okay.
I think so. Dr. Hitchcock, thank you again so much for joining us this week and educating us more on the evidence behind the physical exam, especially for those asymptomatic patients. Next week, again, it will be clinical case review. The format of that will be different than usual. So that one, Zoom only. So no in-person attendance for clinical case review, Zoom only for that. And looking forward to having everyone join us then. Thank you.
You know,